My task today is to share with you the published literature as the lipoaspirate relates to musculoskeletal medicine in humans. Thank you to Steve and to the TOBI team for the invitation to be here today. I appreciate the lipoaspirate graphic that is hovering above us today. So when I began to introduce lipoaspirate into our practice, it was sort of counterintuitive that fat would have a role in sports medicine, orthopedic medicine. Fat always seemed to be a barrier to our patients' recovery, but I think we may be losing some power here. Okay. As Dr. Everts mentioned, Patricia Zook and colleagues at my alma mater, UCLA, identified characteristics of the adipose tissue that suggested that there was a therapeutic potential that was, in their words, enormous. So this is 2001. Now we're 2017, so we'll share the data that has been published since. It was hypothesized that adipose tissue, which was derived from the embryonic mesoderm, would contain cells that were similar to bone marrow, and that mesenchymal stem cells may reside there. And they published a technique to produce the SVF that then showed characteristics of mesenchymal type cells with the ability to differentiate into adipocytes, chondrocytes, myoblasts, and osteoblasts. All right, so the quantity of cells obtained from a bone marrow harvest or a lipoaspirate harvest have been debated, and I'm always amused by the debate when there's a discussion as, you know, fat has twice as many cells or 2,000 times the cells of bone marrow. It reminds me of a bit that Jerry Seinfeld used to do about McDonald's, where he'd say, why is McDonald's still counting? 1 billion hamburgers, 2 billion hamburgers, 3 billion hamburgers, and who cares? He says, I'd like to go to the chairman of the board at McDonald's and say, we all get it. You're selling a lot of hamburgers. Why don't you just put up a sign that says, McDonald's, we're doing very well. And I think cell count is important, but there's so many variables that influence the cells, everything from the harvest technique to the processing to the ways deployed to the additional therapies that will be rendered to that patient, that perhaps outcome is the most important aspect that we should all be measuring, and because it's very difficult for us to measure cells in the clinic. Perhaps allogeneic stem cells in a bottle will solve that problem, where we can actually standardize the treatments that we're offering our patients, but we're not there yet. So adipose tissue also provides a extracellular matrix, which will help cells to adhere and also help them to act synergistically with the MSC. Of course, there are paracrine effects, which we're all familiar with, and then the excretion of cytokines, exosomes, and other substances which have regenerative potential in orthopedic medicine. So in the published lipoaspirate literature, we look at different levels of evidence, and of course we want prospective randomized clinical trials, but we're just not there yet. So we're going to talk about different aspects of different techniques, everything from lipoaspirate to mildly modified tissue, such as emulsification and centrifugation, or perhaps a rinse and microfracture technique, or then the digested and washed and centrifuged SVF product. So in the published literature with regard to cartilage, we have one prospective randomized controlled trial, one retrospective case-controlled series, and then one large multi-center case-controlled study, and several case series reported in literature. The first case series reported was by PAC 2011, where two Korean women with knee osteoarthritis were treated with the SVF protocol described by Zook and colleagues, and this was administered along with hyaluronic acid, PRP, and a nanogram of dexamethasone to help differentiate the cells into a chondrocyte phenotype. And 4 additional monthly PRP treatments were offered to these patients, and they were followed for 12 weeks. And it's a little hard to see on my slide, but you may be able to see that there was clinical improvement both in the VAS and numerical rating index for these 2 patients. again, maybe a little hard to see on that graphic, but in those studies, and you'll have these references in your handout, of course, for you to review later, they were able to demonstrate some changes on MRI to show perhaps some increased thickness of the meniscus in those two patients. Then PAC, again, in 2016, produced 3 additional patients, case series, where in this case they minced the lipoaspirate prior to collagenase digestion in the hopes that it would release more cells. And again, they use a similar protocol where they use HA and PRP, followed by 3 monthly PRP treatments, and again measured their pain and function, and were able to demonstrate improvements in an 87-year-old woman with bilateral knee pain for 20 years, a 68-year-old woman with left knee pain who had had a meniscectomy from medial meniscal tear, and then another patient who had undergone a arthroscopic debridement procedure. And these are, again, images from that paper showing perhaps increased thickness in the cartilage and the meniscus, as well as perhaps decreased bone marrow edema in the medial femoral condyle. Ko, again, out of Seoul, South Korea, produced this retrospective case-control trial, level 3 evidence, 25 patients with knee osteoarthritis with mean age of 54. They excluded patients that had KL4 lesions in more than 2 compartments or had significant varus or valgus deformity or large meniscal tears. And they used a technique where they harvested the infrapatellar fat pad, approximately 9 grams of tissue, and were able to extract 2 million cells, stem cells, and produce an SVF, injected along with PRP, and then that was performed the same day as surgery, and then they also performed weekly PRP for 2 additional weeks, and they followed these patients for a year. And these patients, I should also mention, they had also had arthroscopic debridement and lavage. This was controlled with a group that had simply received the arthroscopic procedure combined with PRP. And what they were able to show was, again, statistically significant improvements in most of the patients as measured by different scales in the SVF group, and less so in patients who were over 55 years of age or who had advanced ICRS grade cartilage injury. The degree of improvement was superior in the SVF group, and there were no major adverse effects. Ko, again, produces prospective randomized clinical trial of 80 patients with femoral grade 3 osteochondral defects greater than 3 centimeters squared. And these patients were randomized to microfracture surgery with SVF and a fibrin glue, or microfracture surgery alone. And these patients were followed for up to 2 years. Both pain and function scores were measured. And 65% of the microfracture and SVF group demonstrated improvement in the cartilage coverage at second look arthroscopy, and 45% in the microfracture group, so a little bit better in the group that received cells along with the surgery. There were significant improvements in the Koos pain subscale, but there were no significant differences in the other subscales. And second look arthroscopy did show good repair of tissue, but there was really no significant difference between the 2 groups. Striano performed this case report. This is the first report of a washed and microfractured protocol for lipoaspirate in a 59-year-old patient who had had a medial meniscectomy and had persistent pain. 5 months later, an ultrasound-guided microfractured lipoaspirate procedure was performed with 5 mLs injected into the joint and 2 mLs injected into the meniscus. And this patient reported immediate improvement of symptoms directly after the procedure. And I would just say anecdotally, I've seen this on occasion as well. I can't explain it necessarily. And then you see this improvement in VAS over the course of 1 year, and improvement in the Koos scores, again, over 1 year. And you see this sort of roller coaster recovery, again, which we see sometimes in some of our patients. And in this study, this is a case report of a patient who had had ACL reconstruction and microfracture and had persistent pain. 10 months later, underwent a second arthroscopic procedure for a persistent osteochondral defect in the, could we go back 1 slide? Maybe not, I can. Oops. And then had a microfractured lipoaspirate injected into the joint, and symptoms improved at 6 weeks and persisted at 12-month follow-up. Improvement persisted at 12-month follow-up. This is a large multi-center case-controlled study performed in the Czech Republic. Dr. Mikulik, there's actually 4 centers, a multi-country trial, and patients were included if they had knee or hip osteoarthritis, predominantly, although other joints were treated. You can see how I've stratified the grades there as far as severity, and these patients, significant of them were overweight or obese based on BMI. 45% of the patients were considered to be candidates for total joint arthroplasty. They used 2 different protocols that they had developed. One used collagenase, one did not. And because they knew they would get more cells with the collagenase protocol, they took more lipoaspirate from the group that did not have collagenase digestion. But the cell counts were roughly equivalent in those 2 groups, and percutaneous injection was performed with or without ultrasound and fluoroscopy, depending if they needed it. These patients were followed for a mean of 17 months, and they showed at 12 months, 63% of the patients showed 75% or better improvement. 91% showed a 50% or better improvement, with no real difference between the 2 groups. As would be expected, the patients who were had higher BMI or were older or had more advanced degenerative changes were slower to respond, but I think it's interesting to note that less than 1% of the patients were actually non-responders, and only 4 of the original 1,100 plus patients received total joint arthroplasty at follow-up. No serious side effects or cancer were noted. Skipping the tendon with my remaining 3 minutes, this prospective randomized controlled trial looked at patients with Achilles tendinopathy for more than 3 months and that had been recalcitrant to conservative care. And they were randomized to either receive PRP or SVF. And they measured the VAS, VISA-A, and American Orthopedic Foot and Ankle Score. This just shows the protocol for PRP and SVF. And there was no significant difference between the 2 groups before treatment, and then they followed them for up to, I believe it's 180 days. Unfortunately, I did not wear my eyeglasses today. I think that's 180 days. And what you see is that there's significant improvement in both groups, whether they receive PRP or SVF, but there is a more rapid reduction in pain and more rapid return of function in the group that received SVF. And it was interesting to note that the lesion size, as measured by MRI, was not reduced. At this point, I insert a shameless plug for my poster, which we'll see at the symposium, which was a case study that we did last year at our practice. 16-year-old girl, this is not in the published literature, 16-year-old girl who had 2-year history of Achilles tendinopathy and tear, and just demonstrating the changes on MRI at 6 months after treating with lipoaspirate, and she's pain-free and able to run. And Kristen Oliver and her also performed a case report of 3 patients with Achilles tendinopathy and partial tear, combining not just emulsified lipoaspirate, but also combining bone marrow and PRP, and were able to demonstrate resolution of symptoms and return of normal function with 3-year follow-up, with evidence of improvement on ultrasound, as you can see here on the left. High-grade partial tear, and on the right, normal appearing Achilles tendon on ultrasound. And then our last study in the disc this year, this case series, N of 15 patients with chronic low back pain, diagnosis having disc degeneration on the basis of MRI, which may be problematic. Discography was not performed. Patients were excluded if they had significant loss of disc height or modic type 3 changes. 60 mLs of lipoaspirate was used to produce 30 to 60 million cells in the form of SVF, and these were injected intranuclear under fluoroscopic guidance, and these patients were followed. Up to 3 discs were injected at a time. They were able to demonstrate some improvement in range of motion, decrease in pain, although not that significant. 10 to 15 patients actually responded. They were able to show some changes in the pain index, present pain index, but no change in the oswestry, and slight improvements in the Dallas Pain Questionnaire and short form McGill. But no serious adverse effects were noted. So going forward, the literature challenges will include, of course, performing randomized placebo-controlled trials. Here we are now, 2017, 16 years after we discovered that the cells have potential, enormous potential. We still have not fully expressed that enormous potential in the published literature, possibly because we have heterogeneous patient populations, possibly because we have our treatments yet, and of course, future studies are going to have to look at the long-term results. Thank you very much.